Hi all, welcome back. This part of the lecture on senses, we're going to talk general senses again, but now we're going to talk about kind of some specialized receptors like thermal receptors and Merkel receptors, so pain receptors, and we're going to talk kind of how they work in just a general sense, but also how they work in different regions of the body and kind of some clinical applications to these. So first, let's talk about thermoreceptors. Okay, so these are temperature receptors. Okay, and remember, majority of the time, a receptor is just a protein. It's a protein that's either associated with other cells that when it is stimulated, it can open a channel and allow for material to move through. In the case when it's associated with, say, free nerve endings, okay, which is what we're talking about here, because we're normally talking about nerves that or senses that are occurring all along the body. Okay, so you have temperature sensors that are everywhere, especially in the epidermis of your body, and these are really just protein gates, okay, that are associated with temperature. Okay, so free nerve endings in the skin. That's where you're going to find these temperature receptors. Okay, and there are two main types, and I think you can probably guess what the two main types are. Okay, you have warm receptors, okay, which are typically sensitive to temperatures, around that 27 degrees Celsius to about 43 degrees Celsius. And then you have cold receptors that are kind of sensitive to about 17 to 25 or so. Okay, and there's obviously some overlap where you got both warm and cold receptors firing when you're at, like, say 79 degrees. You're going to have both firing at that point. And in many cases, you have both firing at different parts of your body because not all of your body is going to be cold, experience cold the same way as uh, other parts of your body might be experience warmth. Okay, outside of this range, though, we're not dealing with thermoreceptors anymore. We're dealing more with a pain receptor because outside of this range, you are starting to produce things that can cause damage to the cells. Okay, and then instead of a sensation of being warm or cool, then you have a sensation of pain, freezing, or burning. Okay, so let's kind of look at how this would look. Okay, so the tip of the neurons or the tip of the nerves are going to have protein channels. Right? You have cold receptors, they are TRPAs and TRPMs and TRPCs. Okay, and there's quite a few different ones, but and it just depends on the range. It depends on the region of the body too, but you have lots of different proteins here. Some are associated with really cold temperatures, okay, which we call noxious cold. So this is potential for cell damage cold. Okay. When the temperatures drop to that point on the receptors in the region of that receptor, so epithelium cells in that region start to experiencing temperatures 17 or below, then you start seeing that these protein channels open up. When they open up, they allow for things like sodium, calcium to flow in. Okay? That's going to change the membrane potential. We've talked about this before. The membrane potential is going to be minus 70 or so. When you have all these positives flow in, it becomes less negative, more positive, and if it makes it to that threshold somewhere around that 55 millivolts, negative 55 millivolts, then an action potential will be sent, okay? And that will be sent from the peripheral nervous system to the central nervous system. You'll get a response, okay, that tells the body, whoa, it's really cold in that region. Right? Drop the block of ice you're holding. Put some clothes on, that kind of thing. From a cold receptor. Okay, heat receptor, same kind of thing, but opposite direction, obviously. Okay, So non-noxious would just be that nice warmth. Okay, same thing with cold. The non-noxious is just, you might feel a little chilled, okay, or a little warm. Okay. Noxious heat, okay, and now we're getting into the extremes. We're talking in the hundreds, and you'll start to trigger certain proteins that open their channels based on temperatures that are much warmer. Okay, same thing happens though. Sodium, calcium, start flowing in, change the membrane potential, okay, and then you get it in action potential formed. Okay, same thing would happen though. And we'll talk about associations. At some point in here, you also trigger other things. So that nerve impulse of those heat receptors may be triggering sweat glands to produce sweat, okay, to try to evaporate, cool the system to get it back into this range over here, okay. And there's lots of systems, lots of sensories that are work together or coupled in a situation when it comes to temperature or really pain or anything. Okay. All right, let's talk a little bit more about that pain, those pain receptors, okay, the nociceptors. Okay. Again, we're talking about free nerve endings, okay, and we're talking about wide distribution all over the body, okay, very important, okay, that you have pain receptors all over your body. Okay. Now, there are certain regions that don't have nociceptors, okay, like the brain, okay, so the brain itself doesn't feel any pain because these receptors are not there. Okay? Now, the outside, okay, the components of the skull, okay, the epithelial cells that are associated with that, there's nociceptors there, okay, but the brain itself, that tissue, lacks pain receptors. Okay? Now, how does it work? Well, it depends on the type of pain. Okay, we just talked about a way that it could work. Extreme temperatures. Okay, you could also have mechanical forces, meaning extreme pressure. Okay, you could have tissue damage, like actually using a sharp object to destroy a cell. Okay, when a cell destroys, it sends out chemicals. Those chemicals are then picked up by these receptors and generate a pain sensation. Okay, it can be chemically based. Okay, this could be chemicals from, say, a poisonous plant or a poisonous insect or anything like that, can cause that. Chemicals that are man-made or not man-made but are, accidentally dropped on the body can cause chemical burns, and it result in pain. Okay. Now, often you will hear that people are adapted or people are more tolerant or less tolerant of pain. You can be more tolerant or less tolerant of pain, but the adaptability is often not not really true. What happens is what we talked about a little bit before, your ability to block out the noise, your ability to cognitive in the brain not send the signal of pain. Okay? It doesn't mean that the pain receptors are not sending the signal. They are. It's just the brain is able to control what's being sent back, okay, to tolerate that pain. Okay, so let's look at just kind of a cross section of skin. Okay, so you have the epidermis, the dermis, the hypodermis. Okay, you have all these free nerve endings. Okay, we talked about how they sense temperature, but they also sense pain. Okay, you have all these corpuscles, that different types, mesenteries, ruffinins, Pachynon. Okay, all these different types, and they have different ways at sensing pressure. Sometimes they're sensitive to just fine pressure, fine movements, enough from a hair follicle being moved could change, the reaction of the skin, and just wind blowing across the skin could cause enough pressure to fire some of these nerves. And then others that really need to be pressed down, and they're going to be associated with pain. And so heavy pressure that might come into play. Okay, so let's talk about the visceral pain. So we talked about the outside, kind of the skin layer pain. Now let's talk about the internal structures. The visceral pain is a little bit different. Okay, so in the case of viscera or visceral pain, we're talking about things like organs, like your heart, your intestines, kidney, liver. The viscera, the connective tissue that's associated with these, will have nerves that are associated with it, but they also, instead of being those free ends that we saw in the epithelium, okay, instead what you normally get is you get connections between epithelium regions and the organ of, or the viscera of interest. And so you kind of get this connection between places, okay? And that's often that connection, or that the feeling pain in a different region, is called referred pain. Okay, so for example, one of the most common examples, and one that you guys probably know very well, is that individuals often that have a heart attack, okay, they feel pain, like shooting pain, extreme pain in their left arm. Okay, that's because that's a common nerve pathway. Okay, so the pain receptors in the left arm are connected to the same region as the pain receptors from the heart. And so they connect to the same spot. And that means that a signal is sent back, and you get a, a kind of sensation in the arm, a referred pain for the heart. Okay. And so let's look at some of the examples of this. Okay, so there's the heart. It's going to send, okay, there's that connection between the left arm and the heart. So that entire region, the pain receptors, they communicate and kind of attach to the same part of the spinal cord. So when you send a response, that response will happen for pain being the entire region, this entire area. Okay, other things that are kind of in non-associated regions, things like your lung and your diaphragm up in your throat. Okay, your liver and your gallbladder up in that throat region, or the top portion of your back along the scapula a little bit. Okay, most are within relatively close proximity to where that material might be, but you might feel things in your back, like if you have something, an issue with your pancreas, you might feel it in the small of your back, okay? And it might feel like back pain, but really it's your pancreas is inflamed or is sending nerve impulses, that something's wrong. There's damage that's there in the pancreas. Okay? And so this is kind of how that works. So let's say there's something wrong with the heart. You have a heart attack, cells are destroyed in the heart, they send chemicals, these nerve fibers are picking that up, it sends a signal, okay? That signal is going to hit a posterior root ganglion, the same region that you have pain receptors coming from the skin. Okay, so these two are in the exact same posterior root ganglion. Okay, they attach to kind of the spinal cord, in the same part, okay, same region, and then signal the brain. Okay, the brain would then send a signal back to the same region. Okay? And so this is how you can get pain in the left arm in the skin, like a burning sensation, okay, when there's something wrong with your heart. Okay? All right, let's look at some pain pathways. Okay? So you have two main types of axon fibers that produce or are kind of associated with pain. And we briefly talked about these already. Okay? You have what we call fast pain, or A deltas. So these are A delta fibers. Okay? They're myelinated. Okay, and we already talked about what it does it mean to be myelinated. It means that the signal can be sent much faster. Their myelinated axons are excellent at conducting impulses really, really fast. Okay, so they have that myelin sheath. We're talking speeds at 30 meters per second. Okay, extremely fast. Okay. Normally, these are associated with sharp pains. Okay, so initial contact, initial pinprick into the finger, okay, or cutting your finger with a knife or something like that. Really sharp pain, but once that stimulus, that initial stimulus, has stopped, okay, then the signal stops. So there's not a long-term pain in this case. It's just you stepped on a tack, boom, there's the pain. You stepped on something, it hurts. Okay? After that, then the second pain fibers would kick in, which we often call C fibers. Okay, they're non-myelinated. Okay, so unmyelinated, so they're slower. Okay, so the conduction is slower, about 2 meters per second. Okay, and this will be that kind of dull pain after the fact. Okay, so you've stepped on a tack, you removed the tack, and then you're just sitting there and you're like, I can still feel it. There's a little bit of pain in that region. It's nice, dull, it's kind of aching. That is the slow pain, or the C fibers. Right, and kind of the process for this would be to take those pain receptors are going to send a signal. Okay, that signal will be sent to the thalamus, okay, then the hypothalamus, then the cerebral cortex, which is then going to interpret that material and send a signal back. And so let's look at that now, okay, kind of how that pathway works, no matter whether we're talking about fast pain receptors or slow pain fibers. The process or the motion is pretty much the same. So how does it work? The thalamus first, okay, that's the beginning of the sensation of pain. Okay, then the cerebral cortex. Okay, so this is thalamus is sensation. Okay, cerebral cortex is more like it is like perception. Okay, so the perception of where's that pain coming from. Okay, so locate the source and judge how intense the pain is. How many action potential signals are being sent. How much influx of calcium and sodium are moving in and continuously sending that impulse. Okay, will give you a judge of the intensity of that pain. Okay, is it just a couple of action potentials, or is it a constant wave of, oh man, this is extreme pain kind of thing? Okay, so in relationship, the sensation, so a little bit, hey, this is pain, okay, this is where it's coming from. Then we have kind of a motor response. Okay, so what's going to happen? Are we going to move our foot? Are we going to move our hand because we set it on something hot and it's burning? What's going to happen? Okay. The gray matter is going to regulate the impulse from the spinal cord. So it regulates kind of the flow of those action potentials. Okay? This is where you could have a little bit of a difference in many individuals. Okay, so how this works, but also how regulated is that impulse? How regulated is that flow? Remember, the receptors themselves are pretty similar in everyone, so you're still going to get the sensation. Okay, but how you judge the sensation, or how you judge the intensity of pain, can be different. Okay, and that also can be regulated by the gray matter of the spine, of the spinal cord. Okay. And then you have things like pain inhibiting substances. So other ways at which individuals could potentially deaden or lower the intensity of pain. So again, pain receptors, they're not really changing. You're not adapting to pain. Your pain receptors are not really adapting. Okay, but what you could have is more individuals with more endorphins or individuals with more serotonin. Okay, and so if your body's producing more of these pain inhibitions, okay, then it could deaden the pain source, and you're an individual that might be able to tolerate pain better, or to a higher degree. If they're producing less and you have, like, your gray matter is causing really high flows of impulses, then maybe a simple pinprick, okay, you could find a very intense pain associated with it. Okay, and different people have different ways at which this goes about, but the receptors themselves are not really the site of that change. So let's look at kind of a clinical application, and this really gets into modern medicine, how this works. Okay, so about 25% of people have moderate to severe pain, just constantly. Okay, and this could be joint pain, muscle pain, headaches, etc. Like lots of pain, and this is like pain is important. It's telling you that there's something wrong in the body, but it also makes it so individuals can't do what they might want to do. Okay, so we often need to treat that pain in some way. So there's lots of different ways that we can treat that pain. Okay? We can use NSAIDs, okay, or non-steroidal anti-inflammatory drugs. Okay, so aspirin, ibuprofen. Okay, these are drugs that I will talk to you about how they work here in a second, but these are drugs that really, they fit in those protein channels and they don't allow for the impulse to be sent. It deadens the impulse in certain regions, so you're not getting the pain being sent on. Okay, issues that are often associated with this is they can cause irritation in the GI tract, and really they can cause damage to other things, and we'll kind of talk about that. Okay, if those don't work, these are what we normally call kind of a mild way to treat pain. Then you can use something like an opiate or an opioid, okay, that deadens the impulse, okay, and doesn't allow those pain receptors to send those impulses. Okay, highly addictive, and we'll talk kind of a little bit about those. Okay, acetaminophen, okay, or in the United States, what we call Tylenol. Typically, it, for many people, is a better alternative, especially if you're going to use it constantly, than aspirin or ibuprofen. It's not addicting. It doesn't irritate the GI tract. However, it does create some damaging. So about 90% of Tylenol can be broken down and passed out, and doesn't damage your liver, your kidneys, anything like that. But about 10% creates a kind of a harmful substance that, if you take too much Tylenol, that harmful substance can build up and cause liver damage. And really, there are lots of efforts to try to get material that can dissolve faster and relieve pain. This is a huge industry to regulate pain and treatment for pains, get away from opioids because of the addiction. Okay, stop using things like aspirin, ibuprofen because of complications that you can have with those. Same thing with Tylenol, but use a different type of approach with things that can dissolve faster, things that have less of a half-life in the system that can be broken down. Don't tax the liver, don't tax the kidney, those kind of things. But till we find them, then that's, they might not be available yet in many cases. Okay, so the other thing is these are just treatments for like typical pain. Okay, chronic pain, there are many treatments, and normally what happens is you get a combination of treatments. You'll get some injections of anesthesia or an anesthetic that stops the firing in that region. Normally these work with removing potassium from the system. Okay. Other things, anti-steroidal drugs, yeah, lots of things. Stimulation of electrical nerves, invasive nerve blocks, so you can put in cortisone shots and things like that, which can block the nerve from firing. But again, nerves are needed. You need to know what the underlying cause is. Of course, individuals that have pain, it's hard for them to carry out what they're going to do in a day if you're constantly in pain, but there's a reason why you're in pain. There's something wrong, and it's better to find out what's wrong than just treat the pain, but we'll get back to that later. All right, let's talk a little bit about natural ways to treat the pain, or kind of natural ways that we do treat the pain. All right, so Zyconidid, it's derived from the venom of cone snails. Okay, glucosamine is derived from crabs of shell, or the shells of crabs and other crustaceans. Okay, so just normal, everyday kind of pain relief can come from natural systems. Okay, some of the ones that you probably are much more familiar with, okay, is opioids coming from poppies. So things like morphine and codeine come from poppies, from the sap of a poppy or the resin of the poppy, certain types of poppies. And then, of course, aspirin is the acetylic acid comes from the bark of willow trees in the salix family, and that's where the salicin kind of chemical comes from. And so there are lots of ways at which we have natural material to treat pain. And then often, if we find that morphine and codeine, maybe they don't work as well, or maybe they're extremely addictive, then chemists can get a hold of them, change the chemical that makes this up a little bit, and produce a synthetic medicine. And that's with all these, you can get synthetic versions of them, and as long as you know the pathway and how it works, then you're good to go. Speaking of that, let's talk real quick about how aspirin works. Okay, so you have these proteins that are embedded in those membranes, okay, and they have these channels, okay, and when you have damage to a group of phospholipids, a special type of phospholipids, you can create arachidonic acid. Arachidonic acid will fit into these active sites, this catalytic site. Okay, when it fits into this active site, it sends a signal. We call that PGH, and then you can get thromboxane synthetase, okay, or prostaglandin synthase. Both of these are intermediate molecules that are needed to produce kind of a nerve or pain response. Okay? Aspirin, how it works is when it's present, that aspirin will fit in a site, and it actually breaks off in a site on the protein, okay, an active site on the protein, and it stays there for a given amount of time, but it doesn't allow for that PGH2 to be produced. Okay, so that's kind of it's a manipulation where it's actually binding to and breaking off on an active site. Okay? Ibuprofen works a little bit like that, okay, but there's no breaking off. It's just fitting in kind of competitively, not allowing for a chondroitic acid to bind. But aspirin itself blocks the catalytic site, and so it doesn't allow for things to flow in. So aspirin is more, in some cases, more damaging because it actually blocks it and leaves a piece of the aspirin molecule in the site. Okay, ibuprofen less so. It just competes, it just sits in there. It's not breaking apart. Okay, and Tylenol may work. Okay, I'm saying this in air quotes. It may work similar, but we don't know. Okay. In fact, most of the research suggests that it doesn't work like this. We don't know how Tylenol works. Okay. We know that it's less invasive than things like aspirin. We think that it could work up here, further upstream, with removing or helping to not allow the phospholipids, the specialized phospholipids, to become a chondroitic acid. Okay, but it could work way downstream, okay, with serotonin, okay, and not allowing serotonin to interact with the molecules and kind of block the signal there. We're unsure. So every time you take a Tylenol, just kind of a word of advice, we don't know how that works. To be honest, we really don't. We know the side effects, most of them. We know it's a safe chemical, but we don't know how it works from that perspective. We do know how it works to reduce fevers. Okay, so you have molecules called pyrons, okay, which are going to generate kind of that fever, entice the fever, and it helps to stop those from being able to do so. But in general, don't know how Tylenol works. All right, so proprioceptors, these are mechanoreceptors that send information from, or information to the central nervous system, to the body, or to indicate the body's position, the length of the skeletal muscles, the tension, etc. So these are things that keep your posture, keep your ability to, a little bit of your ability to balance, your ability to know kind of where your position is on the planet. Okay, so a couple different ones. Okay, we already kind of talked about these. The Pachynoid carpacles. Okay, these are going to sense kind of pressure in the joint regions. Okay, you have spindles that are attached to your muscles. These are going to determine kind of the stretch and the contraction of the muscle. You have tendon organs, or Golgi tendon organs. Okay, so these are stretch receptors that occur in regions of tendons, normally directly associated with the tendon, okay, to kind of determine that stretch, stimulate the reflex and the rebound, etc. And really it protects the muscles from tearing tendons and pulling loose. Okay, so here's looking at just a couple of those. So you have those muscle spindles, kind of the nerve fibers that just wrap around the muscle and determine if the muscle is contracted or relaxed. Okay, and kind of determine that contraction, relaxation. The Golgi tendon organ, okay, associated with the tendons of your muscles. Okay, again, it's determining kind of that stretch on the tendon, and will send a signal for the muscle to relax or retract if the tension is too much in many cases. Okay, and then there's just a lot of other general senses, and we don't have all the time in the world to cover all the general senses, but some are more important than others. Of course, temperature is really important for thermal regulation. That's a huge deal with our body because we are endothermic and we try to maintain a constant body temperature. Our temperature receptors are always active, and they're always determining how much blood flow needs to flow into this region versus this region. Okay, does evaporative cooling needs to occur? Does shivering need to occur? This is constant. Does the erecti pili muscles that control your hair, okay, do they need to be standing up? All these different things associated with thermal receptors. And of course, I'm not taking anything away from the rest of these. The mechanoreceptors, of course, are telling us where we are on the planet, what's touching us, what's not touching us, what direction the wind's blowing from, what you just brush up against. Okay, all these things are associated with just everyday life. Okay. Next up, though, we're going to talk about specialized sensory regions of the body.